In this section, I'm going to present very briefly on the experience of adapting to and addressing COVID-19. As the pandemic hit midway through our planned activities, we, as everyone, had to assess and pivot the portfolio. We assessed each activity in the existing portfolio for its relevance, importance, and feasibility during COVID-19, and then assessed where there could be COVID-related learning opportunities that our partnership would be well positioned to address. In general terms, we have three groupings of adaptations that were made. First, we changed what was being done within some of our studies. This included changing interventions within existing studies to be feasible within the COVID-19 context. It also included introducing COVID-19 safety adaptations, such as ensuring PPE was available, instruction on PPE use, changing meeting modalities to hybrid or remote, and ensuring that we had safety protocols in place for all activities. We also added new data collection activities and changed some data collection modalities. For example, due to uncertainty about being able to collect end-line data, we introduced significant monitoring data collection that was collected throughout implementation and then that did not require additional site visits. We also changed some in-person data collection to remote phone-based data collection. Our second grouping of adaptations was to change where certain activities were done. For example, we consolidated implementation districts to implement an intervention as a package rather than testing individual interventions, which minimized travel, particularly between districts. And third, we developed new activities to capture and facilitate learning related to COVID-19, an example of which I will present on the next slide. A new activity that was developed in response to the pandemic was a case study that investigated what adaptations had been made to ensure the continuity of delivering essential maternity services, the driving forces behind these adaptations, and the impact of these adaptations. This was a mixed methods case study of 6 health facilities, from regional hospitals to primary healthcare centers, in the 2 regions in Madagascar most affected by COVID-19 in the 6 months prior to and the first 6 months during the pandemic. What was found in this case study were examples of a number of adaptations, some of which were focused at the district and facility level, and some of which targeted women and communities directly. For example, at the district and facility level, staff rotations and changes to service scheduling were introduced, as well as changes to physical space within facilities and where clinics were held. Examples of adaptations that targeted women and communities included mass media communications explaining what services were available and when, and transportation services for women to attend clinics, as there were periods when there was no or very limited mass transportation available. While there were some drops in services observed, such as postnatal and family planning visits, there were no significant changes observed in the number of women attending antenatal sessions or delivering in these facilities, nor were there significant changes in the number of obstetric complications, including PPH, during the time periods. In response to these case study findings, a few recommendations for use emerged from discussions amongst national stakeholders. There was interest in expanding the scope to first look at these trends in other facilities, and second, to look at outcomes such as neonatal and maternal deaths using existing data. There was also interest in forming a committee that would review the adaptations that were made along with the trends in service delivery and develop a roadmap for the Ministry of Public Health about which adaptations worked well and where there were still gaps. Although adapting and implementing the APPHC portfolio during the pandemic was challenging, there were some valuable lessons learned. Adaptability and flexibility have been key attributes to maintain over the last year and a half, not just to make our work feasible, but more importantly, to remain relevant to our stakeholders, to respond to critical areas of learning that emerged during the pandemic, and to make this work worth stakeholders' time during a period when everyone was overstretched. We now need to look critically at the adaptations that have been made and evaluate which have longer-term potential to positively transform or increase resiliency in health systems. There are some changes that were made during COVID that were done just to get things done, but there were others, such as the use of online learning platforms, that were feasible and acceptable, and which could contribute to increased resiliency if built into systems. And finally, the implementation science approach we took provided the flexibility to not only adapt to the changing circumstances, but also to balance the scientific rigor of the work with the timeliness and relevance of the work. This is a good demonstration of how to balance these factors and achieve useful results.